Glad you could join us again. This is Michelle.
Hi there.
I just completed an eye examination for Michelle because she's been experiencing bilateral blurred vision.
Yeah, it started a couple days ago and it hasn't gotten any better. I hope I don't have to read anything. Now my eyes are really not right.
The dilation should go back to normal in a few hours.
That'll be a relief.
Here you can see the slit lamp, OCT, and fluorescein angiography results. If it's available, wide field imaging can help. Without it, the peripheral retina, where inflammation is often found, can't be seen clearly, and we run the risk of underestimating the severity of the problem. Is there anything in your medical history we should know about, Michelle?
I have mild asthma. It started as an adult. As a kid, I never had any problems, so I was kind of surprised when my doctor told me that my breathing problems were probably asthma.
Does anything run in your family?
I'm an only child, and my mom and dad are doing great, knock on wood. They're both 70 now. My dad takes something for blood pressure, and my mom has problems with arthritis in her knees, but that's about it.
Okay, that does sound good for 70.
When my vision started getting blurry, I thought I was just tired from jet lag. You see, a dear college friend just got married in India. I'd heard about traditional Indian weddings before, and I wasn't going to let that chance pass me by.
Wow, what an experience. You were right to get this checked out, though. It doesn't seem to be eye strain or fatigue. Do you take anything for your asthma?
I take an albuterol inhaler when I need it, but it's not very often.
Is Michelle's summary, in case you need to refer back to it. Our next step here is to interpret Michelle's eye exam results.
I'll be anxious to hear what you think.
Click Continue when you're ready. Here again are the eye exam results for Michelle.
Ugh, petaloid leakage sounds pretty nasty. What do you think I have?
How would you interpret Michelle's eye exam results? There is one best response this time. What do you think? I agree. Michelle's exam results show anterior, intermediate, and posterior chamber involvement.
That sounds serious.
It can be. That's why it's good that you came in to see us. There are effective treatments.
What exactly is pan-uveitis?
It's inflammation and involves all parts of the inside of the eye. It can be something isolated to the eye, but it can also be caused by another underlying medical issue.
Here I was bragging about how healthy my family is. I'm really starting to worry now.
We'll get to the bottom of what's causing this.
Thanks. I appreciate your help.
Next, we'll discuss possible etiologies for your panuveitis.
Sure, if you say so.
You can click Continue when you're ready. Location should help narrow down the etiology. Given these choices, what do you think is most likely? I agree. Uveitis is sometimes our first clue that something else is going on systemically. Although we can't totally rule out some kind of infection yet, we need to make sure that your eye symptoms aren't the first manifestation of another disorder. There is some evidence that shows systemic disease is more associated with anterior disease rather than panuveitis, but we definitely still have to consider it.
Wow, this is a little overwhelming.
I understand. It's a lot to take in, and I'm sure you weren't expecting to hear all this.
I just expected to leave here with eye drops or something. But, okay. If there's more involved, let's get to the bottom of it.
Click Continue, and we'll decide what additional tests would be useful. All right, as far as testing goes, we'll definitely go ahead with a CMP and CBC. If Michelle's creatinine is abnormal, we could consider getting a urine test for beta-2 microglobulin. We now know that this could be associated with many types of uveitis. At first, it was thought to be seen in children with bilateral anterior uveitis, but it is increasingly being recognized in other types of uveitis and in all age ranges.
I'd rather not go there. Another needle stick and a scary-sounding disease?
There are some other tests here that make sense too. We'll make 4 choices.
Wow, I need 4 more tests?
Quite possibly. What do you think? I agree. With Michelle's travel history, along with her exam, this makes sense. And the interferon gamma release assay blood test is our best option. PPD is valid too, but the one-time blood test is a bit easier, and there is subjectivity to reading the PPD test.
I appreciate not having to come back for a reading, too. Things are busy at work right now, and it seems like I'm going to have to come back for other things. If I can avoid the extra step of a skin test reading, that would be great.
One other thought here. This isn't relevant for Michelle because she doesn't take her inhaler frequently, but TB testing in patients on steroids can be indeterminate.
Why would I need a chest x-ray for my eyes?
We're looking for evidence of tuberculosis or sarcoidosis.
Oh, before I went to India, I remember reading that tuberculosis is more prevalent there. I've heard of sarcoidosis, but I'm not very familiar with it. And I definitely didn't know either of these could have anything to do with my eyes.
Both can cause eye symptoms. Don't worry, I'm here to answer any questions you have as we learn more about what's causing this.
Okay, I appreciate that.
Yes, angiotensin-converting enzyme is often elevated in sarcoid, so this could help us narrow down our differential. Remembering, of course, that ACE is not sensitive or specific. You can have patients without elevated ACE who still have sarcoid, and this can be falsely low in patients taking ACE inhibitors. Just something to keep in mind.
Oh my goodness. Really?
Yes, it's a necessary precaution. The appearance of syphilis in the eye can be variable, affecting any or all chambers in the eye, so this is a good idea. Additionally, many years, even decades, can pass between the initial infection and ocular signs.
Okay, is it a blood test?
Yes. We should make sure to get a treponemal-specific antibody test such as syphilis IgG or another treponemal-specific enzyme immunoassay. If this is positive, we should get a non-treponemal test such as RPR. So, our plan will be to get radiographic chest imaging, syphilis IgG, blood TB testing, and ACE testing. We'll be back once we have those results. If you'd like to talk more about various clinical scenarios and the testing that should be considered in each, click the button on the left with the Discuss icon.
Otherwise, you can click Continue to see my test results.
Right. History and physical exam are often more helpful for making a diagnosis. The idea is that if history and physical examination and basic laboratory studies do not suggest an underlying cause, shotgun testing for specific diseases of low likelihood probably wouldn't be recommended. Michelle's test results. Her chest x-ray was normal, so we decided to get a CT.
I was kind of wondering about that. If it was normal, why get a CT?
Good question. CT is more sensitive. It's better than X-ray at showing us some of the more subtle findings that make us think of diseases like sarcoidosis. If your chest X-ray had been more definitive, we might not need the CT. But in this case, we didn't want to miss anything. Remember, it's also important to get the CT before starting any treatment. As medication takes effect, granulomas may resolve rapidly, confounding clinical findings. Everything looks normal, except that your CT is giving us some clues. I think we have enough information now to select initial treatment. Click Continue when you're ready to make that decision. This time, we have to choose a combination of medications. Don't forget that you can click the eye icons for more information on each choice. Yes, I'd go with this. Michelle's labs aren't indicating infection. It's always important to confirm that before starting a steroid. Typically, I'll try 1 milligram per kilogram of prednisone for 1 week, and then taper by 10 milligrams weekly.
And this is a pill, right?
That's right. Sure, but remember, what we're dealing with here is more extensive than it was in Jim's case, so topical corticosteroids alone wouldn't be sufficient. A combination of topical and oral steroids is indicated. Topical steroids will help with anterior chamber inflammation, and oral steroids will help with the posterior chamber inflammation.
Well, that sounds like we're on the right track then.
It's important to point out that corticosteroids are not recommended for long-term therapy, and we would try not to dose prednisone higher than 60 to 80 milligrams because doses of more than 100 milligrams increase the risk of side effects, such as avascular necrosis. Let's get started with these, and we'll see you back in a week to see if there's any improvement.
Fingers crossed. This is definitely annoying to deal with.
I can understand how it would be. We've seen Michelle each of the past few weeks. Her symptoms had resolved, and her eye exam looked a lot better too, after the first few weeks.
But now my vision just isn't right again. I'm seeing things float across my line of sight.
She began to taper the prednisone, and unfortunately, it looks like we need to take some additional steps here to resolve this. Here are her eye exam results from today.
Ew, there's that petaloid leakage again. Okay, what's next?
At this point, we need to decide on a plan to move forward. You can click Continue when you're ready. There are 2 reasonable management choices to make here. Yes, this is a good idea.
So you're fairly certain there's something more going on then?
That's right. Your CT result, along with the clinical picture I'm seeing, suggests that this could be sarcoidosis. It's best to get Ian involved at this point. Exactly. We'll go back up on the prednisone for the time being.
I thought you mentioned that there are some side effects to be concerned about, being on prednisone long term.
We do want to avoid that. Remember, the risk of glaucoma and cataracts is an important consideration with continued steroid treatment. Not to mention other steroid-related side effects more widely discussed with oral preparations: sodium and fluid retention, alteration in glucose tolerance, weight gain, and high blood pressure, among others. That's why I'd like to get our rheumatologist's opinion. Dr. Ian may want some additional testing, and then we can talk about a new course of therapy.
Okay, got it. I'll get in to see him then.
We won't take up your time right now, but I'll talk to Michelle in detail about sarcoidosis, what it is, symptoms, prognosis, etc. I'll check in again with you after Michelle has been in to see Ian. Hi, Ian.
Hello, Michelle was in to see me earlier today.
Great. What's your impression?
Well, we discussed some additional testing. I should also let you know that I noticed she has several red nodular skin lesions on her shins. She said these appeared 7 to 10 days ago. So that's another piece to the puzzle. I'm curious to see if you agree with my thinking on this, as far as what additional testing would be helpful here. I agree. It's important to check a Hep B panel for immunity and to screen for hepatitis C before starting immunosuppressive therapy. Sure, it's important to check renal, liver function, and glucose levels in this context before starting any therapy. Also, because calcium levels can be high in some patients with sarcoidosis, I'd like to recheck that as well. Yes, I'd recheck Michelle's white blood cells. Some patients with sarcoidosis have slight leukopenia, but prednisone can also cause white blood cells to be elevated. Great. We'll be back when we have Michelle's test results.
Hello again. Hopefully, we're close to getting to the bottom of things.
Yes. Here are Michelle's results, and everything is indeed pointing to sarcoidosis.
I see that her calcium is slightly high, and so is her white blood cell count, since she's still on prednisone. Once again, let's decide on a path forward.
Click Continue when you're ready.
We'll continue Michelle's prednisone until another systemic therapy has kicked in.
I see 2 possible options here that could be appropriate.
Yes, I agree. But we only need one. So, let's use the first A orb for your preferred choice. Then select a second reasonable option with the B orb.
Want to take a shot at this?
Good. Green.
Yes. Because of the severity of Michelle's condition and because she is of childbearing age, this makes sense. Methotrexate is still commonly used in sarcoidosis and to taper off steroids.
From my perspective, it's an option, but it's not our best choice with posterior involvement.
I sometimes start with mycophenolate mofetil. Because Michelle is still of childbearing age, I would be cautious and suggest 2 methods of contraception.
And, just for the sake of discussion, from the ophthalmology perspective, azathioprine, another medication in this class, isn't as effective in uveitis.
And cyclosporin and tacrolimus have undesirable side effects.
Wouldn't you also have to monitor those medications too?
Yes, tacrolimus must be monitored due to concerns over kidney toxicity.
Sounds like there are some reasonable options here, but that others in this class would not be optimal.
So, although methotrexate and mycophenolate mofetil could be considered, my preference would be to try a biologic.
Which biologic do you recommend in this context?
Let's take a look. Ready? I agree, this is an option. Infliximab has been studied in patients refractory to glucocorticoid therapy. Modest improvement has been seen, but long-term treatment hasn't been well studied.
Do you find that patients aren't happy about having to be at an infusion center every 4 to 8 weeks?
Yes, that can be difficult for some patients.
Okay, so with that in mind, now let's use the B orb to select another equally viable option for Michelle.
Yes, adalimumab is approved for panuveitis, and although using it for the treatment of erythema nodosum is off-label, it is used in sarcoidosis. It's a subcutaneous injection, so we'll have to break that news to Michelle.
Yes, we all know she's not thrilled about needles.
Now, because the dose of infliximab can be increased more, it is felt to work better compared with adalimumab. But these are both reasonable options. Great!